I'm going to be talking about our systematic review of interventions for multilingual preschool-aged children. This is part of a larger project that will investigate how to better support multilingual children in Icelandic preschools. I will cover 4 areas in this presentation: describing multilingual children, describing and defining the parameters of the systematic review that we are conducting, results of the systematic review, including both the qualitative synthesis of results and the assessment of study quality, and conclusions and next steps. We are using a broad and inclusive definition of multilingualism, taken from the International Expert Panel on Multilingual Children's Speech. In this definition, people who are multilingual are able to comprehend and/or produce 2 or more languages in oral, manual, or written form with at least a basic level of functional proficiency or use, regardless of the age at which the languages were learned. There are many different ways to categorize and define people who are multilingual, and each can be called a variety of different names. There are 2 often overlapping kinds of bilingualism that we're going to focus on in this presentation: simultaneous and sequential bilinguals. Sequential multilinguals learn languages in sequence, such that a second language is built on top of an already developed first language. Children who start learning an additional language at 3 years or older are often considered sequential multilingual learners because they are learning a language after they have developed a lot of vocabulary, grammatical, and pragmatic skills in another language. For example, a child who learns Polish from birth and arrived in Iceland at 3 years would be a sequential multilingual because they are building their Icelandic skills on top of the skills that they already have in Polish. In contrast to this, simultaneous multilinguals learn 2 or more languages simultaneously. For simultaneous multilinguals, language develop alongside each other, rather than the second language bootstrapping on the skills learned in an earlier acquired language. For example, a child who learns Polish from her parents from birth, but has passively been exposed to Icelandic because she lives in Iceland. She starts learning Icelandic at leikskóla when she's 18 months old, before she has many vocabulary, grammatical, and pragmatic skills in Polish to build on in Icelandic. Multilingualism is a phenomenon that we often overlook the complexity of, and the complexity makes both research and generating evidence-based practices really difficult in research. This slide details some of the ways in which multilingual learners are incredibly diverse across a range of characteristics. Differences in these characteristics can create meaningful differences in children's speech, language, learning, and educational experiences and outcomes, even when they're only considered in preschool-aged children. So in order to determine what evidence-based interventions exist for supporting young multilingual learners, we have conducted a rigorous systematic review of the literature. The team consists of myself, Professor Mark Giberson from the University of Wyoming, and researchers from the Pedals Lab at the University of Cincinnati. We asked 3 related questions in this systematic review. First, which studies have investigated intervention strategies targeting speech, language, and/or early literacy skills in multilingual preschool-aged children with speech and/or language disorders and/or who are at risk of poor speech, language literacy, or educational outcomes? Which interventions reported on in high quality studies have positive outcomes and positive effect sizes related to speech, language, or literacy outcomes for this population? And which interventions have been examined and reported with sufficient rigor to be considered evidence-based interventions for these outcomes in this population? So there are quite a few things to unpack before we get to the results. Within a systematic review, it's very important to carefully define who the target population is, the target outcomes, and the criteria for quality that will be used. So in our review, the parameters are drawn from the research questions. Participants in this study included those who had a knowledge and/or used 2 or more spoken languages, They were aged between 0 and 6 years. They must not have been enrolled in formal or mandatory education. They must have been diagnosed with a speech sound disorder, developmental language disorder, or another speech or language disorder with no associated disabilities, or have been identified as being at risk for difficulties in speech, language, or education outcomes, such as being enrolled in a Head Start preschool in the US. Outcomes of interest were speech production skills, language skills, global communication skills, and early literacy skills, including metalinguistic awareness, reading, writing, and spelling. All kinds of intervention in any setting and by any intervention agent were considered, as long as an intervention was actually conducted and reported on, and pre and post intervention data were collected and results were presented. We took several steps to ensure the rigor and quality of this systematic review. The preferred reporting items for systematic reviews and meta-analyses, or the PRISMA guidelines, were followed in this review, as is the standard protocol now required by high-quality journals. The quality of studies was evaluated using the standards for evidence-based practice in special education guidelines, as is appropriate for educational research. Classifications for interventions as informing the evidence-based practice were also taken for the Council of Exceptional Children's Guidelines. In addition to these, we used double-blind screening of abstracts and data extraction, and reliability was conducted on 55% of studies for the quality assessment. The literature searched was systematically conducted in 7 databases. The tables of contents of 16 relevant journals between 1990 and 2019 were hand searched for articles that could potentially meet the inclusion criteria. The reference lists of all included articles, as well as review articles relevant to the topic identified in the search, were also hand searched for articles that could potentially meet the inclusion criteria. Databases were searched for terms related to the population, risk disorder category, linguistic domains of interest, and for items related to intervention. Inclusion criteria related to the review parameters, which we described earlier. Language of publication was not a criteria for exclusion from this review. From 18,338 records identified, 52 studies were included, which described 4,107 participants. Studies described children with speech sound disorder, developmental language disorder, and at risk of poor outcomes. Reasons for participants being at risk were described in articles as socioeconomic disadvantage and/or identified delay in language or learning without the diagnosis of a disorder. Studies describe children from a variety of locations and who used a variety of languages. Articles reported on participating children living in 10 countries, with the majority coming from the United States, followed by Canada, the UK, Australia, Germany, Luxembourg, South Africa, the Netherlands, and Turkey. The home language most reported across studies was Spanish, followed by English, Arabic, Turkish, and a further 34 home languages. The language of the formal education system in which the children were being prepared to enroll was either stated in the article or inferred. These languages were most often English, but also included French, German, Isikosa, Luxembourgish, and Turkish. The research methodology used in the 52 studies included experimental group comparisons and single case experimental designs. The 52 studies described 57 interventions. Interventions most often targeted language skills. Interventions were most often delivered by speech pathologists and staff from education settings. And this included teachers, teachers' assistants, teachers' aides, paraprofessionals, and general staff. and 25% involved another intervention agent. The interventions most often occurred in an education setting, such as in a preschool. The language or languages which the intervention aimed to improve was most often the community language. And the language or languages in which the interventions were delivered was most often both languages. 29% of these delivered interventions in the home and community languages, and 23% used the community language only in one condition, which was compared to delivery in both languages in another condition. Now, all evidence is not equal. Evidence that comes from studies that are poorly designed, poorly executed, and or poorly reported should not be considered as informing the evidence base for practice. The Council for Exceptional Children's Guidelines from 2014 state that studies are methodologically sound and appropriate for consideration as a source of evidence-based practice if they meet all of the relevant quality indicators. There are 24 indicators for experimental group comparison studies and 22 indicators for single case experimental design studies. Only 14 studies of the 52 met all quality indicators. And this represents 37% of the experimental group comparison studies and 10% of the single case studies. And across all studies, the quality ranged from 29% to 100%. And reduction of the scores was due to a number of possible sources. It could have been that, in fact, the indicator was not met in the study, but it could equally have meant that the indicator was not met in the reporting of the study. So the investigators may have, say, investigated fidelity, but it wasn't reported in the paper, so this couldn't be confirmed. 13 of the 14 high-quality studies described language outcomes and 6 described early literacy outcomes. The majority described an intervention provided in an educational setting and conducted by someone from an education setting. The majority focused on children who were defined as being at risk. All studies reported an effect size greater than 0.25 on at least one of the outcomes measured, remembering that studies could have multiple measures for a single domain. And when viewing these results, it's important to keep in mind that only one study reported a null effect. And this indicates a possible publication bias towards studies, not interventions, that have positive results. Only 2 studies utilized the same intervention, and 3 studies compared the impact of monolingual intervention to bilingual intervention. In all cases, the bilingual intervention provided better outcomes in the language of education than a monolingual intervention. i.e., if you have the same intervention delivered in Icelandic only or Polish and Icelandic, children who get the Polish and Icelandic intervention have greater gains in their Icelandic skills than children who receive the intervention only in Icelandic. The Council for Exceptional Children's Guidelines are very rigid and specific when it comes to the amount and type of evidence an intervention requires to be considered evidence-based. To be considered evidence-based, an intervention requires support from 2 experimental group control studies with random assignment, positive effects, and at least 60 participants. And only one intervention could be considered evidence-based. To be considered potentially informing evidence-based practice, you require support from 1 experimental group study with random assignment and positive effect. And we can see that 7 studies could be considered as potentially informing evidence-based practice. Further, 5 studies met the criteria for insufficient evidence. 4 presented positive outcomes and 1 presented a null outcome. No interventions met the criteria for mixed evidence or null effects. The systematic review highlighted that there's a growing body of evidence relevant to supporting the speech, language, and early literacy development of children who are multilingual and have not yet started formal schooling. Few studies were identified that could provide high quality evidence. The majority of studies were of moderate quality. More methodologically rigorous intervention studies are required to provide an evidence base for practice. Currently available evidence indicates that supporting children in both their home language and the language of their education leads to better outcomes than if the child is only supported in the language of education. There is an urgent need for more replication studies rather than more new interventions in order to inform the evidence base for practice. And for us in Iceland, we need to replicate previous high quality studies which have shown positive effects to identify whether these interventions are relevant and successful in the Icelandic context and to grow the international evidence base. We're continuing to unpack the data obtained in this review, especially regarding language-specific outcomes and whether interventions targeted at and delivered in the home language or the community language make a greater difference to the outcomes of children. Thank you.